Good evening, everybody. As usual, it is IBD Masterclass time at IBDENC. And today our topic is acute severe ulcerative colitis. And it's my great pleasure to introduce to you our keynote address speaker, Professor Simon Travis. He needs no introduction. Personally, he is a guide, friend, mentor, and a global stalwart of inflammatory bowel disease. He is the current professor of clinical gastroenterology at the Newfield Department of Medicine, United Kingdom. Warm welcome, Professor Travis. Thank you so much for being a part of our masterclass. We have the other expert speakers. We have Dr. Naresh Bhatt, who's the Chief of Gastroenterology as the Aster CMI Bangalore. We have Professor Saurav Kedia, Assistant Professor at All India Institute of Medical Sciences. We have Dr. Amit Datta, Consultant Professor of Gastroenterology at the Christian Medical College and Hospital, Vellore. All well-known stalwarts across the country. And of course, we have Dr. Vandana Midha, Professor, Department of Medicine at the DMC College and Hospital in Ludhiana. We have Dr. Lubna Kamani, the consultant at Aga Khan University Hospital, Karachi, Pakistan. Before wasting any more time, I would request Dr. Simon Travis to give the first talk, the keynote address, Diagnosis of Acute Severe Ulcerative Colitis in Routine Clinical Practice. This is important for all of us, do's and don'ts.
Thank you very much indeed. Rupa, you are too kind. And can I just confirm that the audio is working? Thank you, Naresh, for the nod. That's all good. So, do's and don'ts for the diagnosis of acute severe colitis. Let me go through some disclosures which are a little bit unusual. Not those, because it's safety in numbers. It's these disclosures. The first is that I have recently retired from the NHS, and therefore I no longer look after inpatients with acute severe colitis. And with it comes a health warning. Be very aware of the tendency of senior physicians to be dogmatic as they grasp the opportunity to convey their opinions from decades of experience rather than evidence. And you get opinion-based medicine rather than evidence-based medicine. I will try and resist all of that, but it's important to say. So, why is acute severe colitis important? It's because it affects 25% of all patients diagnosed with ulcerative colitis, at least in the UK. We don't know or don't have those data from India, in spite of a lot of recent work on acute severe colitis in Delhi, because there is no population-based study. And yes, it's potentially life-threatening. Even in the UK, a few years ago, the mortality was between 1 and 3%, and 20 years ago, it was much higher in some cases, in some areas. But it matters too, because the colectomy rate when patients are admitted with an episode of acute severe colitis is as high as 40%. In all patients with ulcerative colitis, it helps to patients to know that there's about a 1 in 9-12% chance of being admitted with of needing a colectomy. Well, what is interesting is that in the 3/4 of patients who never get admitted with acute severe colitis, their colectomy rate is only 3%. These numbers are UK based, and they deserve validation in South Asia. The risk of needing a colectomy on admission rises with the number of admissions, and that's hardly to be surprised. And until very recently, the colectomy rate hadn't changed for 40 years, and I will show you evidence around that, but I'm focusing on diagnosis, not overall management, because Saurabh Kedia will be discussing the innovative work that he's been leading on as adjunctive therapy for acute severe colitis. And you would imagine that we would know when patients are sick and need admitting, but we don't, because I get caught out, and I still do see patients and outpatients in private practice, and I need to apply objective criteria to determine severity at every clinic, because it's so easy to underestimate the severity, because patients may have been on steroids, playing down symptoms, or the physician may not hear the severity, and then there's the inevitable prevarication because there aren't any beds to admit, and therefore the threshold increases. But the consequences of diagnostic delay is that it delays treatment when hours and days matter. And every time you see a person with toxic megacolon, it represents a missed or delayed diagnosis of acute severe colitis. And I mentioned that the mortality was very much higher in some places. Well, in a UK district general hospital, 20 miles from London, in the year 2000, that's this century, they had a mortality of 24% of patients when they ordered it, because patients were admitted under any general physician. They changed that, but nevertheless, it's shocking what might be the case. And furthermore, there's no ICD-10 code for acute severe colitis. Therefore, you have to keep your record. So, number one, do's and don'ts. Use objective criteria for making a diagnosis. Don't expect to be able to track such patients and their outcomes from hospital records. And hey, top tip, auditing your hospital's outcome is a great project for a registrar, and we can get data. So here are the objective criteria. Sidney Truelove at the top, on the right, and Leslie Witts below him, there's Regis Professor, and they're clinical criteria that have stood the test of time. Bloody diarrhea 6 or more times daily with a tachycardia temperature, hemoglobin anemia, or a high ESR, or high CRP. And they are simple. And the number of criteria, in addition to bloody stool frequency, correlate with outcome. So, number two, do's and don'ts. Simple. When you're in clinic and you have a patient who's complains of bloody diarrhea and has colitis, diagnosed with ulcerative colitis of 6 or more times a day, then for goodness sake, make a note of their pulse rate and measure their temperature there and then, because those are immediate points. And of course, you send off their hemoglobin and CRP. And sometimes, if you're saying that a patient needs admitting and they're a bit doubtful, then I arrange a plain abdominal X-ray there and then, because you can estimate the extent of the disease. And if there's fecal loading around on the left colon, well, hey, they're not in any danger. But if they've got an empty colon, then they've got a pancolitis, because the distal distribution of fecal residue approximates the proximal extent of inflammation. And the second don't is, don't just prescribe steroids and see them next week. I said as if they're, because our clinics are overburdened and we wouldn't have the capacity to do so. And beware the temptation just to arrange immediate anti-TNF therapy in the hope it'll avoid admission, simply because there's no evidence that that is safe and effective, and the risks, especially where there's a high prevalence of infection, are substantial. And so another top tip: establish a standard practice for your own hospital, which all your colleagues who see patients with IBD agree to follow, because that reduces variation in care and increases patient confidence. Now, Vineet Ahuja set up a study with Saresh Jain a little while back to see whether the True Love and Wicks criteria applied in India. And he made the case that because hemoglobin was lower in general in the Indian population, maybe the hemoglobin was not relevant, or that there might be a tendency to overdiagnose it. And the study looked at 59 patients with acute severe colitis admission to aims according to the standard criteria you see in the top left there. And all patients had one additional criterion, even when the hemoglobin criterion was excluded. And you'll note that 2/3 had a hemoglobin of less than 10.5 grams per DL, and yet all of those had an additional criterion. You only need one additional criterion, in addition to a bloody stool frequency of 6 or more a day, to make a diagnosis of acute severe colitis. So he proposed that True Love and Wicks criteria can be applied to an Indian population, but without the hemoglobin. Indeed, went on to Jeth and Saurabh, who will be speaking next, led this particular study to see whether the clinical criteria could be dispensed with altogether. And there was a group of patients with ulcerative colitis, half of whom had mild and moderately active disease, and half of whom were hospitalized. By checking the fecal calprotectin, then there was a clear cut-off in fecal calprotectin of over 780 micrograms per gram, which gave excellent diagnostic accuracy to differentiate acute severe colitis from mild to moderate UC. I hesitate, though, we couldn't use that in practice in Oxford, simply because we don't get the fecal calprotectin result returned in an expedient manner. But nevertheless, it's a useful metric and objective measure, which takes the individual clinician decision and overall subjective impression of the sickness of the patient out of the equation. So you've got to expect the expected. It may appear unexpected, but actually, if a quarter of patients with diagnosed with the UC will develop acute severe colitis, then the question arises, can you actually predict it? And yes, you certainly can. And basically, another top tip is that the more severe the colitis is at presentation, then the more likely the patient is to develop acute severe colitis over the next 3 years. So be prepared. This is a prognostic index we developed and have validated in 2 other centres, one in the UK, one in Sweden. And it looks complex, but is quite simple. If you have extensive colitis, that's E3 distribution, and a high CRP, that's above 10 milligrams per litre, and you've got a hemoglobin less than WHO criteria, that's 14 for men and 12 for women, with units, of course, grams per deciliter, and you score 1 point for each, then the risk of developing acute severe colitis in the next 3 years is between 73 and 100%. And these are the data. I won't go through it in detail, other than to point out that in Cambridge, 18 of their patients, they had almost 100 patients, 18 of their patients at diagnosis scored 3 out of 3 on those criteria, and all of them developed acute severe colitis. In Uppsala, they had a much larger cohort of around 300 patients, and only 6% of those were admitted with acute severe colitis, but it still predicted the 13 out of those 14 patients. So further do's and don'ts: do use objective criteria for assessing severity at diagnosis. Don't always start the same treatment. I tease my surgical colleagues, they always start Azocol because A is for Azocol, and they start at the first letter of the alphabet, and steroids, and they can just about remember predfoam, so they give them some sort of hydrocortisone enema. Regardless of severity, you've got to tailor your treatment to the severity of the disease. And another top tip, another good project for a registrar, is to see whether this index for predicting acute severe colitis might be validated in India, where hemoglobin is low. So this is the when patients are admitted, and I do believe that patients with acute severe colitis should be admitted, and I'll come on to that in just a tick. They get a plain film, they do stool samples, flexible sigmoidoscopy, they're started on steroids. I'm not going to go into any of the grey areas in any way, sorry, I will be talking about the enteral nutrition. But using these, tracking those patients is important. And people ask, well, why do you admit somebody who otherwise looks well? Just because they've got a bloody stool frequency and a single additional true Leavenworth criteria? Well, my answer to that is, if I had a 10% chance of needing a colectomy on that admission, I would prefer to be in hospital. And these are the UK data, our data from Oxford. And the true Leavenworth criteria, whether you have 1 additional, 2, 3, or 4 additional criteria in addition to the bloody stool frequency of 6 or more times daily. Now, if you've just got 1 additional criterion, you've got a 9% chance of colectomy, and this is in a group of 300 missions, and it tapers off as about a 50-50 when you've got 3 or 4. So that's why you should apply those criteria. So count the number of additional criteria on admission, and use that predicted colectomy rate to inform your own approach, not only to the patient, but also, of course, their family. And don't pretend to the patient, staff, or yourself that it'll all be okay, because sometimes it isn't. And that means that contingency planning is central to the optimal management of acute severe colitis. Why do an abdominal X-ray when you might get a CT? Well, an X-ray is universally available at very short notice. The physician can look and learn to read the mucosal edema, the mucosal islands, and it's and I mentioned the way of assessing the extent of it, depending on the distribution of the fecal residue. And I reserve a CT only for patients in whom I'm worried about a perforation if they've got pain, and it's a pretty high radiation dose for our younger patients. Germans use ultrasound, but I've never seen objective data related to outcomes around that. And of course, within that, the diagnostic dilemma is the risk of infection, particularly prevalent in India and Pakistan. And of course, you send a stool sample for C. diff assay and other pathogens, including Shigella and other infections and protozoal infections. but do check that your lab does measure both toxin A and toxin B. And it's still, I would advise, I don't in the UK, but for India and Pakistan, I would have, and other places where infection is prevalent, it's reasonable to assume that there is an infectious trigger until cultures are negative. But on the other hand, don't wait until cultures are negative before starting steroids. And don't assume that you can ever educate your general medical and infectious diseases colleague that it might be ulcerative colitis and acute severe colitis instead of infective colitis. I've been completely unable to do that in Oxford in the past 20 years. And for that reason, this other top tip is to treat both, treat AS with both steroids and antibiotics together whilst awaiting for results. And I think that's, although there are randomized controlled trials, adding or not adding antibiotics to steroids, and which haven't shown a benefit of antibiotics, I think where infection is prevalent, it seems to be the counsel of caution. And then, of course, you've got to exclude CMV. You do a flexi, both to confirm the diagnosis. You do that urgently. Take the biopsies and measure the ulcerative colitis endoscopic index severity. I'm not going to go through this, but it's the three descriptors have been related to the success of treatment and the likelihood of colectomy. And we published this data some years ago now with Crispin Court is showing that if you've got a UCIS of 7 or 8 out of 8, then almost everybody needed rescue therapy with cyclosporin or infliximab, or came to colectomy. And CMV matters, and my approach to managing CMV and the possibility of CMV is to suspect it in patients who've got a very high temperature, 40 degrees. It's disproportionately high to their other to the rest of the condition, and I then, especially if they're on azathioprine or steroids, and then a range of flexible sigmoidoscopy and ask the pathologist to get on and do an H&E scan. They can turn it around in 12 hours. Promise you, they just need to engage gear. And if they've got RSI inclusion bodies, then I start treatment. And then, of course, you can quantify. I use PCR to quantify the viral load, and in addition to managing these patients, I use steroids, but then I'll stop the azathioprine. But once again, AIMS have been doing some work around this, and they've been using the tissue PCR to look for CMV. And a study which was published last year suggested that that a high proportion of patients has a tenfold risk of not responding to steroids if there is CMV detected or DNA detected on PCR. Vineet assures me you can get results within 24 hours, faster than immunohistochemistry. And so my do's and don'ts here are to send biopsies for CMV, both H&E and immunohistochemistry. Check your lab if they can do quantitative PCR, and if they can, well, by all means request it. And don't ever forget about the possibility of coexistent infection in addition to acute severe colitis. And that top tip is you pick up the phone, speak to the pathologist if you want a rapid response, and they're usually, pathologists actually like being phoned by clinicians. And I mentioned, and just wrapping up now, that the colectomy rate hadn't changed for 40 years, but now it has. And this is a study by Dan Turner 15 years ago now, showing that the colectomy rate was around 30% for patients admitted with acute severe colitis, and the various diamonds colored or not depend on whether or not they have cyclosporin. This was all pre-infliximab era. And then we've done work which shows the colectomy rate has halved. You can see Sidney Truelove's original colectomy rate on the left there, back around 30, and the blue circles are all the Oxford data. And so what's done? Well, here are the data, which are under review by Gut at this moment. And look on the right, you've got the colectomy data. The salmon pink bars are those that we published back when we were looking at the three-day predictive index, 29% colectomy. The light blue bars on the right are the colectomy rate now. It's 15%, so it's halved. Well, what's changed is rescue therapy. So look to your left, and you can see that half of our patients now get rescue therapy as opposed to a quarter. And there seems that whilst rescue therapy with either cyclosporine or infliximab has doubled, the colectomy rate has halved. Here are the numbers that we used to develop this a further index. Once again, indices help point the way for difficult clinical decisions, and it's a point-based system. CRP of over 100 milligrams per liter, that's high. But also, though we had no patients with coexistent infection, but that might include that, a low albumin, albumin less than or equal to 25 grams per liter, that's low, with using the ECIS of endoscopic severity, get to a 1 point. And if you score 4 out of 4, look to the bottom right of that table, no patient responded to conventional steroids. And it's quite a useful index because this can be done on the day of admission, not on the third day. So to conclude, the do's: be prepared. Consider the risk of acute severe colitis at diagnosis because you can predict it over the following 3 years if they've got a high CRP, extensive colitis and anemia. Secondly, be objective. If you see a patient in clinic with bloody diarrhea 6 or more times daily, then check their pulse and their temperature. And be aware. Be aware for coexistent infection with C. diff or CMV, and treat both infection and colitis with steroids if there's any question about that. Don't wait for the cultures to come back negative before starting steroids. And be cautious, yes, but be decisive. So use these indices, and that admit ASC score that I've just mentioned has been validated in Delhi, not just in Oxford and the Gold Coast in Australia, but also in Delhi. And if the patient scores 4 out of 4, then do not expect them to respond to steroids. They need rescue therapy with cyclosporine or infliximab. And you can also use the Ames index, which combines the endoscopic severity and the fecal calprotectin. And so that's it. That's where I used to be working at the John Radcliffe Hospital in Oxford. It always looks very nice. And if you're in Oxford, you can come and visit me at the Kennedy Institute, where I was offered a job only yesterday in translational research into inflammation. And I hope together we can help treat more patients with colitis more successfully and find a cure for this awful condition. Thank you very much indeed.
Thank you, Simon. I think I can only say it was a fantastic talk. And I personally have learnt a lot. And I think for routine practice, particularly in the South Asian context, simple things that you have mentioned, including the X-ray, will make a lot of difference. And I think whatever you have said can be done easily in our context. There are a lot of questions coming, Simon, but I think we'll finish the talks first. And as Dr. Naresh Bhatt gets into the case discussion, we will of course hear your opinions, so we will know more. So Our next speaker is also very well known in the field of IBD in India. He has a huge amount of publications, some of which already Simon has mentioned. And he's going to talk today on exclusive enteral nutrition in ulcerative colitis, whether that can be a new strategy in acute severe ulcerative colitis. Over to you, Saurabh.
Thank you, ma'am. Thank you for this kind introduction and thanks for this opportunity. I'll just take a moment to share my screen. So is my screen visible now?
Yes, it is, Saurabh. You just make it full screen. Yes, perfect.
Okay, yeah. So Professor Travis has already outlined the basic approach to the diagnosis and the initial management of acute severe colitis. So now I have been given the task to talk about the role of exclusive enteral nutrition in this setting. So I'll start off with the basic pathogenesis of UC, which we are all aware that it's an inflammatory destruction of the colonic epithelium because of an aberrant immune response, which occurs in the genetically predisposed individuals under the environmental influences which affect the microbiome, and diet is one of the major contributors which affect the microbiome. The epidemiological studies have already shown that diet is linked with the risk of IBD, and the so-called Western diet rich in animal protein, total fat, omega-6 fatty acids, high refined sugars, soft drinks have been associated with the increased risk of ulcerative colitis, while prudent diets such as fiber, especially from the fruits and vegetables, higher intake of vegetables, omega-3 fatty acids, vitamin D and zinc have been associated with the reduced risk of IBD. Similarly, diet has also been associated with the relapse in patients with IBD, and these two studies, which although were published some time back, showed again that high intake of processed food, red meat, saturated fat was associated with the increased risk of relapse in patients with ulcerative colitis who were in remission. So, if we look at the current therapy of IBD, most of these therapies suppress the immune response downstream of the pathogenic pathway and are associated with limited efficacy, side effects, and loss of response, while diet would act upstream and would be a more physiological therapy and associated with sustained response. So now what are the types of dietary interventions which have been tried or are being used in IBD? So the most extreme form is the exclusive enteral nutrition, which is meant as dietary foods for special medical purposes, independent of the route of application, given exclusively. And then we have the exclusion diets, which eliminate some form of pro-inflammatory constituents from the diet and could be more acceptable for a long-term use. So how does exclusive enteral nutrition work in improving the disease activity? So, well, the EN targets multiple pathways. So as we have already seen that diet influences the microbiome. So the EN has been shown to cause decreased microbiome diversity, but it reduces the pathogenic taxa and might lead to improvement in the beneficial bacteria such as firmicutes. It also improves the epithelial barrier, resulting in decreased translocation of the bacterial products which cause inflammation. It acts also on the immune cells, causing decreased pro-inflammatory cytokine production and increased anti-inflammatory cytokine production. And it also reduces the antigenic load to the intestine, thereby leading to improved intestinal barrier and mucosal healing. Now, if we look at the evidence, so diet as a therapy in Crohn's disease is well established, and exclusive enteral nutrition has been shown to be comparable to steroids in inducing remission, better in causing mucosal healing. It has been advocated as a first-line therapy for pediatric IBD across multiple guidelines. The evidence is building up in adults and has been useful in patients with complicated Crohn's disease. The exclusion diets such as Crohn's disease exclusion diet again have been shown to be efficacious in the induction of remission in multiple studies. And partial enteral nutrition again has been shown to be efficacious in maintaining remission in patients with Crohn's disease. But what about dietary recommendation in ulcerative colitis? Is it still a mystery? So again, we don't have definite answers for these questions. Is diet helpful in UC? If so, as a primary therapy or as an adjunct therapy? Does it only cause nutritional benefit or will lead to therapeutic benefit? So which type of diet should be advised? What with the relation to disease severity in patients with acute severe colitis, while patients with mild to moderate colitis who are managed as outpatient basis, and any difference in between children and adults. So the notion is that the evidence on diet in patients with UC is weak or there is no evidence. But does this absence of evidence means that there is no evidence or there is no data for UC? So let us go back to the history. So this study was published in 1949, 6 years before the first randomized controlled trial of steroids in ulcerative colitis was published by Sidney Truda. So this study looked at 14 patients with severe ulcerative colitis ranging from 13 to 60 years. They had a wide range of disease duration and the stool frequency was more than 6 in all the patients. The intervention was a low residue liquid diet, somewhat similar to the current day EN preparations, consisting of casein hydrolysate and dextromaltose. This diet was administered at 200 to 400 ml every 2 hours, and at the end of median of 4 weeks, what it caused was it improved the general well-being of the patients. Fever, which was present in more than 50% patients, disappeared. There was weight gain. There was improvement in stool frequency. There was improvement in the endoscopic appearance as well, and all patients could resume normal activity. So this trial, published more than 70 years back, gave a proof that enteral nutrition could be efficacious in patients with ulcerative colitis as well. This was followed by several dietary manipulation studies in patients with ulcerative colitis, including and again, this a trial was published by Sidney Truda, who published the trial on corticosteroid. He included 77 patients with acute UC, some of which were inpatients, some were outpatients, and he included randomized the patients into dairy-free, low-fiber diet versus a controlled diet, and he showed that the patients in the elimination diet had a reduced risk of relapse over the next 12 months. Now, if we look at the other studies which have been published in patients with acute severe ulcerative colitis, then there were 3 studies which compared bowel rest, that is total parenteral nutrition, with the normal diet, and it showed that the outcomes were similar in both the groups. In fact, the risk of infection increased in patients on TPN. Then 2 studies compared exclusive enteral nutrition with TPN, again similar outcomes in both the groups. However, the nutritional improvement was better with EN and the complications were less with EN. Then we had a RCT which compared EN with the normal diet. It showed that EN was well tolerated and there was a trend towards reduction in collectivity rates in patients in the EN group. Then the 2 uncontrolled studies which used elemental diet and EN both again showed that EN was tolerated. It led to remission in about 50% patients, which was maintained on follow-up in 50% patients. What about the elimination diets? Most of these diets have been tried in patients with mild to moderate UC. The type of elimination diets have differed, ranging from the food intolerance to IBD-based exclusion diets, and most of these diets have shown some improvement in the disease activity of these patients. So, what have we learned so far? In patients with acute severe colitis, total parenteral nutrition is not of use. It has been abandoned. Normal diet is similar to TPN. However, EN has shown some signal of benefit over normal diet in these patients. In patients with mild to moderate UC, elimination diets may be beneficial. However, they have variable formulations which have been used. So, what we don't know is, in patients with severe UC, is EN really useful? If yes, in which setting? What would be the preparation which could be useful? What would be the dose? What would be the duration? And would it be useful as a primary therapy or as an adjunct therapy? In mild to moderate UC, again, which elimination diet to be used? What would be the duration of use? Again, a primary versus adjunct therapy, and induction versus maintenance. Well, to answer these questions, in patients with acute severe colitis, that is EN useful and which preparation and how to use it, we have these 2 gentlemen who deliberated and who planned a study to answer the relevance of exclusive enteral nutrition in patients with acute severe ulcerative colitis. So this was the trial which was published about a year back, and the basic premise for this study was the EN lead to improvement in the outcomes in patients with ulcerative colitis. So this is the basic care pathway in patients with acute severe colitis, wherein we start the patients on IV steroid. We assess the response at day 3 by the Oxford criteria, again proposed by Professor Travis. And in the patients, in the non-responders or the partial responders, we then go for medical rescue therapy or colectomy. If we see, then till date also 40% patients will fail IV steroids. Salvage therapy, though useful, though has led to reduced colectomy rate, is associated with costs and side effects. And emergency colectomy again is associated with morbidity as compared to elective colectomy in these patients. So the basic objective of this study was whether EN can lead to improvement in response rate to intravenous steroids. So this study included patients with acute severe ulcerative colitis who satisfied the 2 love and Ibd criteria. They were adults who did not receive IV steroids before being admitted to our hospital. The intervention was standard of care, that is intravenous hydrocortisone 400 milligrams a day versus standard of care plus exclusive enteral nutrition, and the duration of EN was 7 days. So the preparation which we used in this study was Peptamen, because it was easily available in our hospital. It's a semi-elemental preparation which uses whey protein as the protein source in the form of oligopeptides. 68% of the fat is in the form of medium chain triglycerides. It has added vitamins and minerals, so patient does not need anything else except for this. The 100 gram of Peptamen contains 55 grams of carbohydrate, 18 grams of protein, and fat in the form of MCT and PUFA. And the calorie density is about 450 kilocalories per 100 gram of EN. However, this administered, the amount was calculated based upon the patient's body mass index. It was prepared by mixing it gently in the lukewarm water to ensure that there is no lump formation for better tolerance of the patient, and dilution in excess water was avoided to prevent nausea and vomiting in the patients. The feed could either be a minor feed when 20 to 30 grams were dissolved in about 100 to 150 ml of water and was given 2 hourly, or it could be a major feed. Sorry for this error, which in there about 40 to 50 grams were dissolved with about 200 ml of water and was given at a bit higher interval. So the patients were advised to drink slowly, sip by sip, so that the tolerance improved. The feed was usually started with a minor feed, progressing to major feed if the patient tolerated. And to reduce, if the patient developed bloating or nausea, then the quantity was reduced and the frequency was increased. So this was way in how this EN was administered. And importantly, the patients were monitored rigorously by our dietitians as to their problems and any challenges which they faced while taking the EN. So the primary outcome measure was the proportion of patients with corticosteroid failure. It was defined as any need for rescue therapy or colectomy. The secondary outcomes include colectomy during the hospitalization, changes in the inflammatory parameters, adverse events, and the response to salvage medical therapy. And in the patients who had more than 6 months of follow-up, we again compared colectomy and hospitalization between the 2 groups. So we look at the results. Then the baseline clinical parameters was comparable between the 2 groups, including the markers of severity such as the number of 2 love and Ibd criteria, the pulse rate, and the day 1 stroke frequency. The lab parameters again, which indicated the disease severity such as albumin, ESR, CRP, and the UCIS at baseline was again comparable between the 2 groups. So we come on to the outcomes. Then we look at the primary outcomes, that is the rate of steroid failure. Then both in the intention to treat population, 5 patients were intolerant to EN. However, the ITT analysis included all the patients. Here the steroid failure rate was lower in the EN group as compared to the standard of care group, but the difference just reached statistical significance. In the per protocol analysis, which excluded the patients who were intolerant to EN, the steroid failure rate was significantly lower in the EN group as compared to the standard of care group. And if we look at the other way around, then in the EN group, 75% patients improved on IV steroids as compared to 57% patients who improved only with the standard of care. And this figure matched our previous data and the data from the other sectors. If we look at the secondary outcomes, then the duration of hospitalization was lower in the EN group as compared to the standard of care group. Other outcomes including colectomy, response to rescue medical therapy, and adverse events was comparable between the 2 groups. Looking at the biochemical parameters, then the day 3 fecal calprotectin was significantly lower in the EN group as compared to the standard of care group, and the decline of FCP was again significant in the EN group when compared to the standard of care group. The CRP declined significantly in both the groups. However, the day 5 CRP was again lower in the EN group as compared to the standard of care group, and the delta CRP again was higher. That is, there was higher reduction of CRP in the EN group as compared to the standard of care group. If we look at the other parameter, albumin, the albumin improved significantly in the EN as compared to standard of care group, and at the day 7, both the day 7 protein and albumin were higher in the EN arm. Among the long-term outcomes, the colectomy rate, though lower in the EN group, was not statistically significant, and the composite outcome of colectomy or repeat hospitalization was again lower in the EN group as compared to the standard of care group. So at the 6 months of follow-up, 84% patients in the EN group avoided colectomy or repeat hospitalization as compared to only 61% patients in the standard of care group. If we look at the microbiome analysis, then at the day 1, the microbiome was similar between the two groups in terms of alpha diversity, compositional analysis, and the beta diversity. The microbiome clustered closely between both the groups. However, at day 7, there was separation of the microbiome in the two groups, with almost reached the statistical significance. And if we look at the compositional analysis, then the frequency of abundance of erysipelotrichiaceae was higher in the EN group, and this order of the microbe has been associated with the reduced risk of IBD, and it has been shown to have reduced abundance in patients who have active IBD. In the control group, the abundance of Veillonella, which again has been shown to be associated with IBD, and Streptococcus C was higher. So there was a trend towards microbiome improvement in the EN group as compared to the standard of care group. So we summarize the results of this study. So there was low steroid failure in the exclusive enteral nutrition arm. There was reduced hospitalization, the reduced duration of hospitalization in the EN arm. The biochemical parameters in the form of FCP, CRP, and albumin improved better in the EN group. There were better long-term outcomes, and there was trend towards better microbiome profile in the EN group. So the question is, will EN or is EN a new strategy in acute severe ulcerative colitis? Well, the results of this study are encouraging, but it requires validation from other centers nationally as well as globally. In the end, I would thank our IBD team under the leadership of Professor Vinita Ahuja and Professor Travis for the insights on this study, and this was supported by our IBD fellows, by our dietitians, by our PhD students who did the microbiome analysis. Thank you.
Thank you, Saurav. Thank you for a fantastic talk as usual, but also to have given us another area which we often don't focus on, but is easily achievable. We can do it. I am definitely, I feel that we can actually validate it very quickly within the Indian scenario in other centers, and this is such an interesting way to go forward. Again, lot of questions are coming in for Saurav as well, but we will take the questions at the end of the session. And now for the case of the day, and over to you, Dr. Naresh, for the case. And of course, the panelists are Dr. Amit Datta from CMC Vellore, Dr. Lubna Kumari from Pakistan, and Dr. Vandana Midha from CMC Ludhiana. Over to you, sir.
Thank you, Rupa. Thank you for having me over this evening. And I'd like to welcome all the panelists, Dr. Vandana, Dr. Amit, Dr. Lubna, and Saurabh. And my job is basically to act as the on-field umpire. And whenever we have trouble, we go on to the third umpire, and I refer it to the big man himself, Professor Simon Travis. I have listened to Professor Travis several times on acute severe ulcerative colitis, and every time I learn something new. Even some of the slides, I have seen them earlier, but more meaningful information emerges even from those slides. Lovely to have you here with us this evening, Simon. Okay. To start off, this is a 28-year-old lady who's single, a bank clerk, who first saw us in August 2021. She was managed by one of my younger colleagues in the unit. She had a 4-month history of increased stool frequency, 4 to 5 per day. There was mucus, no blood. There was tenesmus. On evaluation, her hemoglobin was 10.2. Her counts were reasonably normal, including her platelets, and the CRP was slightly elevated at 10. She had full-length colonoscopy, and we established a diagnosis of ulcerative colitis. The extent of the disease was from the rectum to the hepatic flexure. The Mayo endoscopy score was 2. Sorry, Simon, our guys still are reluctant to use the UCIs. And of course, we made the biopsies confirm that it was compatible with the diagnosis of chronic UC.
Naresh, just a little tip there. Simply create a table on an A4 size piece of paper and stick it up in every endoscopy room. That's what I did in Oxford, and everybody, they didn't do it because I told them to, but when they're writing their reports and they see the UCIS, just those 3 descriptors, they find it really, they all use it now simply because it's a more objective way of describing what you see. But that's what we've done.
So that's a gentle schoolmaster getting things done just by putting a little notice there.
Yeah, and not digital, Naresh, but just so that it reminds them. Because, but anyway, that's just a minor tip.
A very point well taken. So we had a diagnosis of IBD ulcerative colitis, mild to moderate, extent E3. She was started on oral 5-ASA at 3.6 grams a day, and in 3 weeks' time, she had a greater response. Now the story now re-emerges 6 months later, that is earlier this year, in March, where she came to us with worsening of symptoms for a week. There was stool frequency of 8 to 10 per day. There's blood and mucus. There's no fever, no pain abdomen, no recent travel. Examination revealed mild pallor. She was afebrile. She had a mild tachycardia at 110 per minute. Her blood pressures were good, and the abdomen was soft, non-tender, and she had hyperperistaltic sounds. So, Amit, I'd like you to answer this question. Is there some way this relapse could have been anticipated or prevented?
So, I think so. One is that after we saw her the first time and we made the diagnosis, did we have a follow-up in between for the patient? Like, did she come to clinic after the initial therapy to see if the other parameters, because only clinical response cannot be the entire thing.
She came and said, I am doing well. So she was just continued on the same dose of 5-ASA. But your point is well taken. We didn't do any tests. What would you have done?
Probably done a CRP and calprotectin to see how those markers are, because obviously we don't have to repeat a scopy. So the clinical things of stool frequency, blood in stool, and then some biochemical parameters will be sort of okay. And also look at the hemoglobin, albumin, how things are keeping up. But more importantly, the inflammatory markers and the stool frequencies.
Okay. Is there anything in the phenotype of this patient which told us that, yes, this patient would have a relapse? Because anything like we have this, we stratify them according to the risk. Anything in this patient that
yes, so she has an E3, there is a risk. But what I think is that what she was managed with is actually okay. I mean, we do manage patients with the 5-ASA when they come to mild to moderate disease. So it's basically just to have a follow-up. But so although there is a chance of having a thing, I don't think management was anything differently could have done apart from a follow-up part which I was talking about.
So we could have followed up later, ensured that she had reached a normal CRP and she had a downward trend of her fecal calprotectin, and that would have told us that perhaps she was less likely to relapse.
But the risk will remain. But I think treatment-wise, it's like, okay, what happened is all that is what I personally feel. We cannot understand.
Okay. Simon, anything quickly that you want to add?
Yes, very briefly, using that predictive index at diagnosis that I mentioned, she scores 3 out of 3. So therefore, she was likely to be admitted or to develop an episode of acute severe colitis. Her CRP was just on the edge, but she had extensive disease. Her hemoglobin, okay, it's in India, as we had that discussion, but that's why I think it would be useful to replicate that study in India. However, what we don't know is that with those people at high risk of developing acute severe colitis, whether you should wade in with more effective maintenance therapy. What I would do, though, is check that she was taking the 5-ASA that she had been prescribed.
Okay. So coming back to Amit, what tests do you want to order? Simon has told us. What do you want to order?
So essentially, so I think if you look at the current situation, like even based on what we presented, she looks like she's had acute severe ulcerative colitis. She satisfies the Tulum and Witts criteria for a severe colitis. So I think in this group of patients, we have I divide them into 4 groups of investigations. One is look at the patient's general condition, then look at the severity of inflammation. In superadded infection, especially in tropical countries, is very important, and also to prepare for a future rescue therapy if the current therapy fails. So for the general condition, probably the CBC, LFT, creatinine, sodium, potassium would be an X-ray abdomen for her actually. For severity, a CRP, calprotectin, and this thing. Infection, stool parasite, stool culture, and stool C. diff toxin, as Professor Travis said. And then we'll do her workup post like a chest X-ray or a interferon gamma for a probable biological thing. And within 24 hours, proctosigmoidoscopy and prepares. That will be the investigation.
Thank you, Abid. So this is what she had. You agree that these are the things that you wanted? We're giving you that. Hemoglobin was a little over 9.1. Her counts were borderline at 10,300. Platelets were good. CRP was sky high at 115. And her albumin was already down at 2.9. And the stool routine obviously showed exudate, and there were no trophozoites of entamoeba. Amit, do you see a lot of entamoeba causing problems in your patients with ulcerative colitis?
So we had actually published, we had about a series of 40 patients with acute severe colitis and looked at all the infections in them. Totally, we had 8 infections, which were CMV, in 2 had C. difficile and 3 had strongyloids. But we didn't have any amoeba in that series of 40 patients, which we saw. That was a period of 2 years that study was conducted as a part of postgraduate thesis. But we had strongyloids, we had CMV, C. diff, but we didn't have any amoeba in that series. Although every patient we sent for amoeba parasite and culture and C. diff toxin.
Saurav, any comment on the entamoeba in your unit?
Yeah, sir, we also don't see usually amoeba precipitating or amoebic colitis coexisting or precipitating ulcerative colitis. Sometimes there are patients who present with IBD-like features and they turn out to be MBSs, but both of them coexisting, we usually don't see, sir.
This business of C. difficile toxin assay, is this now routine in all your patients with acute, the relapse in ulcerative colitis?
Yeah. So for all patients with acute severe colitis who are admitted, we send a C. diff toxin assay.
Okay, so that's standard of care.
Yes, sir.
As Simon also mentioned, and obviously he also mentioned that stool cultures are important as well. Okay.
So a question to Professor Travis. So is C. diff toxin assay to rule out C. diff colitis, or should we send GDH along with it? And if the GDH is positive and toxin is negative, we go for PCR, or the toxin assay is sufficient?
So the technique, as long as you're looking for for toxin A and B, I don't think it matters whether you need to do the to look for the bug, but we routinely, for our inpatients, we routinely send C. diff assay, and we don't routinely send CMV PCR to be honest with you. We only do it in selected cases with a very high temperature.
Simon, just a simple question for the Indian context. Supposing there's a patient with fever and there is acute severe ulcerative colitis as well, do you think it's advisable to start empirical broad spectrum antibiotics?
Short answer, yes. But there are fevers and fevers, aren't there? It's a matter of degree. If you get a fever simply with acute severe colitis, then it's a cardinal feature, but it's rarely above 38.5. When it gets up to 40, that's when I really worry about CMB. Now, of course, you can get infective colitis, and that can send your temperature up. But I think in India and Pakistan and other areas, I would absolutely give antibiotics. Which antibiotics? Well, then metronidazole needs to be in there because you mentioned the intermediate issue, and then whatever's locally active against the Campylobacter and Shigella and whatnot. But
because we have a tendency
usually a quinoline. But I would definitely do so. Yes, I wouldn't wait. You can stop them as soon as you get culture negative.
Yes.
But the danger for
Dr. Lubna, are you there?
Yes.
Simple
Few
question.
months ago, I have a comment. Few months ago, there was an outbreak of salmonella in Karachi and nearby areas and rural areas and interior Sindh. And we saw a lot of patients presenting to us with, acute severe colitis who are already having ulcerative colitis and are stable for last many years. And then in stool culture, we found Salmonella typhi in these patients. So again, in India, Salmonella is one endemic, so we need to consider along with Campylobacter and Shigella.
All right, we'll come back to this issue. A simple question for you, Dr. Lubna. Is this acute severe ulcerative colitis according to the definition?
Yes, according to international definition, yes. But if you ask for the modified Asian, then of course, because we see a lot of low hemoglobin. So hemoglobin usually especially in females, the normal hemoglobin is around 9 or 10. And I guess my Indian colleagues will agree. But if you see the international definition of acute severe colitis, then yes, diarrhea more than 6. But sometimes, even if this is the definition we all accept, but if you see a lot of patients and if you have an experience, even if the patients are not matching this criteria, still they can have acute severe colitis. When you go there, you do your sigmoidoscopy, or they behave like acute severe colitis. They have toxic megacolon. Still the pulse rate would be 80, 85, or they are afebrile, but on X-ray, there will be toxic megacolon. So yes, if you go by books, yes, it is a definition of severe ulcerative colitis, but then the clinical condition you have to match.
Simon, I'd like your comment on this because
only briefly, Naresh, and to say that you do not need a full house of all the additional criteria to make the diagnosis. And that really comes back to Lubna's nice point that you only need one additional criterion. And there's a worry, and I've seen it once or twice, when patients get toxic megacolon, then the stool frequency can go down. So be careful about that. But they will have been through the acute severe colitis phase, and it's why abdominal X-ray should be part and parcel of the initial management.
Okay, so this patient, anyone like to comment on ESR versus CRP, or have you all moved to CRP now?
All moved to CRP, I suspect. I mean, and we've tried to do some work. We reckon it's about 30 milligrams per liter, but actually, it's a pretty arbitrary measure. She only had a 10 milligrams per liter at diagnosis, but she had 115 milligrams. So she's got nasty colitis, albumin going down. This lass is sick.
Okay. All right. So an X-ray abdomen, Simon spoke about it and fairly eloquently, and I'm just putting up this picture. This was her picture. Looked quite okay to us. And this is what you can see when you have trouble. Amit, would you just want to make a quick comment on what you're seeing on this X-ray? This is some other patient.
So as I said, sir, X-ray is a very important part of monitoring the patients, even initially as well as during the therapy part. It can give you a lot of information, but the main thing we're looking at is the dilatation of colon, especially the transverse colon actually. And so obviously, I think the other features as well, we look for like edema or mucosal islands. But the critical thing is the diameter of colon, especially in transverse colon. If it goes beyond 5.5 to 6, we start suspecting it's a toxic megacolon is developing at that stage.
Okay, Amit, in your practice, do you just do it on day 1? And then what happens subsequently on day 3, D5? Do you repeat this, or only the patient is not doing well? Do you consider doing X-ray or a CT scan? What is the kind of knowledge that you give us?
So definitely we do it at admission, but ideally I think if you look at the guidelines, they say you should do it every day for first 4 to 5 days, but we don't do it daily in our practice. I think we look at the patient's clinical condition, the stool frequency, the pulse, temperature, other parameters, and abdomen examination as well. And as Professor Travis was saying, stool frequency sometimes coming down in a toxic patient also suggests a toxic megacolon is developing. So look at those parameters as well. But we don't do daily. It depends more on clinical profile, but first day we do, and probably we repeat once after that. We don't do daily actually.
So, Vandana, to ask you a question, when your patient is, what do you monitor in your patients on a daily basis?
Yeah, apart from the history, the number of stools, the blood and stool present or not present, we look into the general physical examination, the pallor, the pulse is important, temperature is important, abdominal distension is important, tenderness is important. We look for these factors daily on a routine basis.
So important is to continue doing a clinical examination often to pick up subtle signs of deterioration and things like that. Okay, thank you.
Can I just chip in there, Naresh? Because absolutely look at the abdomen. I would never bother to worry about measuring the girth or anything like that in technical terms. No, it's stool frequency, and I completely agree with Amit about not doing abdominal X-rays on a daily basis. You do it if you're worried. If there's a disconnect, somebody's got a tachycardia or they develop a temperature or something when their stool frequency is going down and there's it doesn't seem to match, then you repeat it at that stage.
So would you do an X-ray or would you do a CT? Again, going back to the
it depends on the diameter. If they've got a dilated colon, on admission, then I will repeat it the following day and until I'm sure it's going down. If they develop pain, I'll definitely do a CT scan. But if the plain film looks as this last when she came in, you could see fecal residue on the right side of the colon without a dilated colon, I wouldn't bother repeating that unless there was any other evidence of deterioration.
Okay, moving on again, Dr. Vandana, back to you. Would you do a colonoscopy or a sigmoidoscopy? Would you give a preparation or is it an unprepped colon? And what about biopsies? Do you take one side or like the pathologist want from many sides, and the number, the technique? Would you like to comment on that?
Yeah, as far as a full-length colonoscopy is concerned, it is not warranted because the risk of perforation is more. We usually go in for an unprepared, limited sigmoidoscopy, and we do take biopsies with minimal air insufflation. So this biopsy, what are we going to gain? We are going to gain we're going to see the severity of the disease, which would help us in the prognostication later. And it would help us in taking biopsies to rule out CMV, which has been considered a trigger in a significant percentage of patients with acute.
Where would you take the biopsies from?
Limited sigmoidoscopy is done. So
just for the rectum?
Even the colon.
So how many biopsies do you normally give your
I'm not sure of the number of biopsies which are taken, but what has been proposed is 11, but which is not practical, and it is usually 1 or 2 biopsies which are taken in this case.
Simon, how greedy are your pathologists in Oxford?
I'd take 2 pairs. Take a pair from the sigmoid, pair from the rectum, be done with it. I hesitate just to take them from the rectum, because if they get, what's that term that pathologists use, sort of destroyed in processing or flushed away or something like that. No, I take 2 pairs, and they can use the same blocks for tissue for doing looking for immunohistochemistry for CMV, but usually it's just you're just looking for an H&E response.
Okay. All right. So this is the sigmoidoscopy that this patient had. Just a short video. Okay. So some pictures from the rectum and the sigmoid. Amit, what is your interpretation and what are you going to do?
So I think straight away looking at this deep ulcer, this is a severe disease actually, as we've been discussing, and then we'll have to take biopsy, and we also send, so when we send a biopsy, we tell them histopathology as well as immunohistochemistry for CMV, but we also send a CMV PCR in addition to these for our patients when they get admitted with a flare. So we'll send another one more bit for a couple of bits for a CMV PCR as well, apart from the.
Now they say the yield of biopsies for CMV is when you take it in the base. Now, how confident are you of doing that in this kind of patient with deep ulcers?
That's true. I think, I don't know, so that what they talk about in the esophagus, whether it holds true, but I think it's actually a scary situation, especially when you have deep ulcer. If it's not a deep ulcer, it's all right. But when the ulcer is deep, probably I think you can't probably dig and take multiple bits from there.
Simon, question for you. Would you routinely send biopsies for CMV in all ASUC? And no, where would you biopsy from?
I do not. I do not. Specifically do not. Though I was a little bit shocked when the AIMS data, when I first saw it, about the prevalence of CMV. So it is different. And I've often, when traveling around the world, I do see areas where it is more common, and CMV complicating acute severe colitis may well be more common in India, so maybe routine, and if you've got the lab can do CMV PCR, that's fine. The reason I was pulling faces is those are horrid ulcers. The place you do not biopsy is in the base of one of those ulcers. Don't. And indeed, when you're putting, you see that sort of thing and you're putting the scope in, make sure your finger is on the wash button, not on the insufflate button, because when patients perforate at flexi for acute severe colitis, it's not by the scope going through the wall, it's often because something pops higher up with too much air insufflation. So plenty of fluid, and biopsy one of those red lumpy bits, not the white, the deep craters. And I would be worried about CMV here simply because of the depth and how punched out those ulcers are.
Okay, what we did was we, as Amit had suggested, we took biopsies of histopathology and alerted our pathologists that yes, we think CMV may be possible. We asked for a tissue CMV PCR, and we also got a serum CMV PCR assay, and we'll come to that discussion in a while. But the initial management was planned by our registrar, planned IV fluids, IV hydrocortisone, heparin, and he said there were electrolytes were a little low. He planned correcting that there was anemia, and topical therapy. So, Lubna, are you there? Lubna, are you there?
Yeah.
Yeah, okay. So the question is, where would you manage this patient? Would you just send him off to some other hospital? Would you put him in your wards or in the intensive care unit?
Actually, before answering this question, just a quick comment regarding Dr. Travers, that we need to give less air in order to avoid perforation. We have buttons in Olympus scopes, like to high, medium, and low air. So when I usually do sigmoidoscopy, I put on low air basically. So in that case, the flow of air is less as compared to routine. Routinely, we put the button on high. So if you put it on the low, I guess the flow of the air is less. So that is one thing that we can,
Okay, thank you.
Regarding the admission and the management of this patient needs to be managed in a tertiary care hospital where there are facilities available round the clock of ICU, of the surgeons are available, the CT scan and the full-fledged gastroenterology unit is present.
Look, we have a long way to go. Can it be just a little brief because we have a long way to go? Sorry.
Okay. So this patient needs to be managed in tertiary care hospital in a high dependency unit, either an HDU or an ICU. And again, every hospital has their own protocol. We follow a standard protocol. We start these patients with routine blood testing. We need to get surgeons in loop. We give them antibiotics. We send them labs, the cultures, the IV hydrocortisone. And for initial period till we rule out any surgical cause, we keep them NPO for 24 hours because we need to get a sigmoidoscopy. We need to stabilize the patient. We need to rule out the perforation, but we don't keep this patient long, more than 24 hours NPO. If they are stable, we start feeding after 24 hours. And yes, of course, we are living in a third world country, in a developing country. We need to give antibiotics, a broad spectrum antibiotics, covering both Entamoeba histolytica and gram-negative bacteria.
Okay, I'll stop you at this stage. Amit, antibiotics, yes or no?
Yeah, so it's we don't have a uniform policy for everybody to give antibiotics.
Okay, Saurabh?
Yes.
Yeah, sir. So
Antibiotics, yes or no?
Yeah, we usually give antibiotics when a patient with ASUC is hospitalized for the initial 4 to 5 days.
Vandana?
We do give.
You give antibiotics. Rupak, I can drag you into this. Do you give antibiotics?
Yeah, we do give. If there is fever, then 100%. Otherwise, we sometimes take a close call depending on the clinical condition of the patient.
Okay, so we don't use antibiotics routinely unless we're convinced that there's infection in some way. But anyway, we just move on to the next issue. How are you going to feed this patient? I think, Saurabh, maybe you need to again reinforce what you told us in that lovely talk of yours.
Yeah. So what we are now following is that we are giving the trial was with the semi-winter preparation, but now we are giving a polymeric preparation, and we started from day one, and we usually give it for 5 to 6 days in the initial 5 to 6 days of the.
Sorry, this polymeric is something that most people may not understand. Can you be a little more specific? What do you give them?
Yeah, so like Ian has 3 categories based upon the protein formulations. We have the elemental, we have the semi-elemental, and the polymeric. So elemental has the protein in the form of the short chain amino acids. The semi-elemental has it in the form of oligopeptides, and the polymeric has the whole protein formulation. So polymeric is more palatable, less costly, and more physiological.
So you would we agree with Lubna that you keep them NPO for 24 hours, or would you start feeding them upfront? Saurabh?
So we start them upfront unless and until there are signs of toxic vagabula. Otherwise, we start the nutrition upfront.
Saurabh, I'll take this thing to ask. Multiple questions have come on your exclusive enteral nutrition, but I thought I'll just ask one right here. It says that how do you taper exclusive enteral nutrition after treatment success?
So we usually switch the patient to a normal diet that is because it has been used only for a short duration, 5 to 6 days. So we usually switch the patient. If the patient tolerates, patient has improved, we switch him to the normal diet. There is no specific tapering protocol.
It's changed our practice in Oxford actually. We now use enteral nutrition and using the polymeric peptamen formula because it's palatable, but it's completely changed our practice. I can't see a downside to doing it, quite honestly. And if there's an upside, well, I'm all for it. So that's why we've changed practice.
Okay, now we'll go to this intriguing business of CMV, right, Amit? Simon said that he suspects the CMV in all patients. He said no. What about you? Do you suspect CMV in all patients, or did biopsy, or only in a selected few? And what tests that you do, you said, but let's go through this again.
So all the patients who get admitted with acute severe colitis, when we do sigmoidoscopy, we send sample for CMV. We alert the pathologist so they can do an immunohistochemistry, and we send a tissue sample for PCR as well. And if somebody we are going to treat for CMV, then in that patient we even do a blood PCR, which is again not a very established thing, but that it gives a bit of an idea when we are treating whether the patient is the count. So blood PCR only if we are going to treat somebody, but for initial diagnosis it's a tissue which we send and a tissue PCR and the immunohistochemistry on that. And every patient with ASUC, when we admit, we do it for us.
Vandana, what is your protocol in your place?
We are doing CMV, IgG and M, as well as we are taking the biopsies and sending them for histopathology.
All patients?
All patients and immunohistochemistry. And we alert our pathologist for an early report.
All right. So as Simon said, the cytopathic changes or the outline appearance is perhaps the most specific, may not be so sensitive, but most specific as compared to the tissue IHC and the tissue PCR. Can I have a quick comment on this, Simon?
Was that to me, Naresh?
Or what would you believe when you send them multiple tests? I mean, do you believe and would you react to all the reports or would you react to?
Not at all. No, one has to distinguish between CMV disease and CMV infection. We've all got CMV infection and it's usually latent. And so has it got down to disease? H&E owl's eyes are pretty reliable, and the occasional owl's eye intranuclear inclusion body doesn't mean anything. But if you get a crop of them, and of course we still do immunohistochemistry, we only do blood CMV PCR. The virologist will only allow us to do that to monitor valganciclovir therapy. So we don't routinely do it, but that's because in our view our CMV infection rate is actually rather low, very low. 1 or 2 cases a year. Then so I would focus on the tissue, and if you've got access to CMV PCR on tissue, hey, that's great, use it and be guided by that.
Okay, thank you. So we have a lot of data which is not clear whether CMV is just an innocent bystander or a major player. There are data on both sides. One says it exacerbates disease, one says it's no effects. So Simon, when do you treat for CMV? And what do you expect from the treatment?
When there's tissue disease and patients and they're systemically unwell, so they've got disease, then we will treat with valganciclovir. We will continue treating the acute severe colitis. We'll stop azathioprine if they're on it, but I haven't prescribed azathioprine for treating ulcerative colitis other than protective response for infliximab since the pandemic started. And then valganciclovir, and I'll be guided by our virologists. Our virologists hold our hands when we do that. And this is, and you can expect the outcome to be worse with any infection, whether it's C. diff, CMV, or whatever, if they've got that as well as their acute severe colitis. So if they've got a pre-existing diagnosis of ulcerative colitis and they've got CMV as well, they're likely to have both. And as Lubna very nicely said with the Salmonella story from Karachi, that in fact that triggers off presentations. Infection will trigger off acute severe colitis. And as for therapies that might worsen CMV, well, only azathioprine, steroids, and this is from our transplant surgeons and who see much more of it. They're quite comfortable with steroids in these circumstances, even though it predisposes to acquiring it.
So again, these various societies have different recommendations, but we'll take Simon's word that steroids and cyclosporin might increase the risk of CMV, but biologics perhaps are reasonably safe. Is that okay?
I think so. Yeah, I'm afraid one knows the literature and it's confused, but basically I look on azathioprine as the culprit for increasing the risk of viral infections, and biologics, that by that I mean anti-TNF therapy, for bacterial infections. In a rough, as a rule of thumb for a clinician, it's guidance. Share your problems. If you get in your own practice, you've got a dilemma like this, pick up the phone and speak to somebody, because a problem shared is a problem halved.
And that's exactly what we did. Simon, I anticipated what you would say. So we decided that we would start ganciclovir for whatever it was worth because of the deep ulcers. We started therapy. We only got a serum CMV which was very high. The tissue did not show us anything. The biopsies didn't show any cytopathic changes. So a day or two later, we stopped the ganciclovir. The question was whether to give steroids, biologics, or cyclosporin. We asked for a special help, and the help said give them steroids. Is that okay, Abid?
Yes, sir. I think I would actually start steroid in this patient because
Vandana, Lubna.
Yes, steroids would be.
Yes, I guess steroids might be life-saving for the patient because the bottom disease is ulcerative colitis. So yes, you are giving ganciclovir and you can continue with the steroid.
Okay, thank you. All right, so now, Vandana, how long do you wait after giving IV hydrocortisone? When do you start reacting? I mean, patient is, there's no calamity, like there's no perforation or distension of the colon. How long do you wait?
Usually by 3 to 5 days, we have to think of other alternatives if the patient is not responding. We look into the stool frequency, we look into the CRP levels, we look into the fecal calprotectin, and these are the pointers in case the patient is not responsive. We have to consider for an alternative rescue therapy by 3 to 5 days.
Okay, so you don't wait much longer. No. Waiting longer may be deleterious. Okay.
Yeah.
All right, now this question is a little tricky. Amit, do you use any prediction index or indices? And if you do, which one? And how does it change your therapy? Or do you resort to the Indian thing of either reading the palm or looking at the horoscope?
So I think actually we do apply this Oxford criteria, but to tell you the truth, actually we don't go strictly by criteria. They are more probably for uniformity in research, I guess. For clinical practice, we look at the patient's general condition, how he's doing. But these criteria can be a good guide to, to also say that, okay, you're on the right track. So, but we do use the Oxford criteria out of enough patients when we use criteria.
Simon, I want your perspective on this. How does it change? I mean, it's good to write a paper with this thing, but how does it really change management?
It informs your approach to the patient or the family, and I'm all about contingency planning. So the way that it changed, and we've traditionally used the 3rd day index. So this is day 1 is admission day, day 2 is the day after, and so on that 3rd day, that's what day 3 is, not 72 hours of intravenous steroids. It's quite an important point. So it's the 3rd day index. But if they meet those criteria, in other words, they've still got a CRP of above 45 milligrams per litre and a stool frequency between 3 and 8, then we ask for a surgeon to come and see them. We also, simply as a contingency, we actually also, since surgery has been mentioned, ask the stoma therapist to come and see them. And then, and we do that in parallel with that day deciding on rescue therapy. And so we absolutely decide on rescue therapy. Whether we are going to change with this first day, this admit ASC index that I touched on, and it does look as though she meets those criteria for not responding to steroids. Whether that means that we should start the that cyclosporin or infliximab right at the very beginning, I think is an unanswered question, and I would all the questions about infection and so on come into play there. So on the 3rd day, we absolutely apply that, and we decide on rescue therapy that day, not hang around where if you hang on and you kick the can down the road, you think, gosh, I wish I'd started this 2 days ago. And and it's unlikely to do any harm, either cyclosporin or infliximab in these circumstances.
So you make a very strong point for using the third day assessment to decide that, and you feel that is clinical practice.
Yeah, I'm biased, of course, but on the other hand, I've felt it's when I've avoided it and I've ignored it because there's only a guide, I've regretted it. And so these are really difficult patients, the most difficult patients that luminal gastroenterologists ever look after. And you're talking about a 25-year-old bank clerk who you're faced having colectomy, 25-year-old girl having a colectomy, big, major life-changing decision. These are the biggest decisions you'll ever make. So I think that you need something to back up your judgment.
Thank you. So anyway, she completed 3 days of hydrocortisone. Stool frequency was about 8 to 9 per day. There's still blood, tachycardia. Abdomen, though, was soft and non-tender. CRP is higher at 128. What next and why? Saurabh, what's your choice? Cyclosporin surgery. What do you want?
So the day 3 parameters indicate that she's a non-responder to IV steroid. The stool frequency has not changed. She still has blood. The tachycardia probably has increased, and the CRP has also gone up. Although we usually wait for 2 more days, wait till 5 days in our practice, but in this patient, the day 3 still suggests that this patient is not going to respond. So this patient would be counseled for the options of the rescue therapy between infliximab surgery and cyclosporin. The surgeons will be called, they will see the patient, and then the patients will also be given the option to take a decision whether she wants a surgery, infliximab or cyclosporin.
Okay, right.
Difficult.
Yes, sir.
You've got CMV here as well as colitis.
Okay, I told you the CMV we didn't, except for the serum PCR.
Oh, right. I misunderstood.
Most of it was off.
Point taken. Okay. All right. Correct. Okay.
So we have this data that both are equally effective, cyclosporin or infliximab. So what are you going to choose, and what is the basis that you're going to take this decision? Vandana?
Yeah, so first of all, it will be depending upon the physician preference as well as the patient choice. We need to give them the options for both cyclosporin as well as for infliximab. In case we are contemplating surgery, definitely we should be favoring cyclosporin use. And there is more data which is now available for infliximab. The toxicity profile is more with cyclosporin, so it has to be tailored according to the individual needs, and the rescue therapy has to be planned accordingly. If the patient has failed prior thiopurines, so our choice would go more in favor of infliximab than cyclosporin, because once we are tapering the cyclosporin and adding on the thiopurines, it is not going to work.
Vandana, can I just I would take a different perspective, actually, because looking at this girl on the third, she's now effectively the 4th day, but she's had 3 days of intravenous steroid. Her CRP is still 128. She's still got a tachycardia. I'd be worried about this girl. This is one of the circumstances I would actually repeat a plain film, but that's and because of that, I reckon the risk of surgery is reasonably high. So to be honest with you, I would opt for cyclosporin in this girl and get the surgeons. And I'm interested, nobody's mentioned about ability to fund cyclosporin or infliximab, but don't let that be a deciding factor.
Okay, is tacrolimus an option to cyclosporin? Simon, or?
I mean, no, there such trials that have been. It's popular in Japan, popular in Germany, but TAC is it is it's a calcineurin antagonist, and therefore should work, and may certainly the longer term it's less toxic than cyclosporin. If you were in Ann Arbor, in Michigan, then Peter Higgins would wade in with tofacitinib, and actually Topha is pretty inexpensive in India, I think, but at high dose, 30 milligrams daily is what they're using for rescue therapy, and they've written up small case reports, and we've actually published in Gastroenterology the mechanism of action of why JAKis can
So what about TAC? Would you use, or you don't use TAC?
No, we don't use it.
You stick to cyclosporin.
Yeah, we just stick to cyclosporin. Yeah.
All right. Okay. Now this patient is sick. His CRP is high. We saw those deep ulcers. Would you consider infliximab rather than cyclosporin now?
And that's a question for me. I would, for the reasons that I'd be worried, and look at those ulcers, they're shockingly deep. I would be actually, the surgery really is a worry. And so infliximab, once you launch the Exocet, then there's no calling it back. And it hangs around for a number of weeks, and the worry about postoperative infection is what concerns me. So I would be hesitant about infection, but I would discuss with colleagues and make a joint decision, of course.
But isn't there some recent data that infliximab is not as bad postoperatively as was thought earlier? Dr. Travis, I was just sort of reading some time ago that infliximab may not be as bad as it is thought for a post-operative thing, or is it like sort of?
Yeah, I mean the data are still it's very, very confused because of they're relatively small numbers of patients with acute severe colitis, and they're all about colectomy whilst they're receiving infliximab, and the post-operative infection rate, if you just standard colectomy, is not increased. But then that in all the studies I've seen to date, they had a very, very small number of people with emergency colectomy for acute severe colitis. Very different thing, I think.
Okay, anyway, this is the options. So we decided to go for infliximab, right or wrong, we'll see. We gave her a standard dose of 5 mg per kg. So question to you, Vandana, or Lubna, if you're there. How critical is this choice between cyclosporin and infliximab? Does it matter if there's no contraindication to either? I mean, would I be making a mistake? Simon said you prefer cyclosporin. I have used infliximab. Would it be very critical? Is that a mistake?
If you see in Pakistan, apart from contraindication, you have to see other things as well, the cost. Because in
okay, that's fine. All things considered, the government of Pakistan and the government of India are paying for it, so it's all right. Just imagine.
No, I don't think so. We can use either. There aren't any contraindication. I basically prefer infliximab over cyclosporin because I have more experience in infliximab. But if there are contraindication to infliximab, then I go to cyclosporin.
Vandana?
Yeah, I agree with that, but the dosage of infliximab in lieu of low albumin levels may be that we give it a higher dose, maybe 10 milligram per kg. And if we are contemplating surgery, then definitely cyclosporin, apart from rapid onset of action and a reversal, would be the choice.
A quick comment from you, Simon. How critical is this choice?
No. I absolutely
angry for this.
You showed us the CISIS study and our construct study. They work equally well. It's not a hanging offence to use one or the other, so that's fine. And she may well get away with it. And as for people, everyone is more familiar with infliximab these days than cyclosporin. But the 2 milligrams kilogram intravenous dose is actually very well tolerated, and that's, we use about 50-50 actually in our practice for rescue therapy. It's about half.
Okay. She completed her rescue therapy with steroids, infliximab, 7 to 8 stools per day, still some blood, little better maybe. Pulse rate has come down to 90. but CRP is still high. What do we do? Open to all of you. Maybe starting with Vandana. What would you do?
I would think of surgery.
Surgery. Amit?
Yes, sir, I think surgery should be now. So already there is 7 to 8, so surgery should be considered. So frequency is high, CRP is very high.
Okay, you're working in India. The Simon said 26-year-old girl, single, not married, whole
Can we
future
give
ahead
another
of her.
dose of
And
infliximab?
as expected, she refuses surgery. I mean, that's a fact. So
Can
what
I-
are we going to do?
No, I was just wondering, can we give another dose of infliximab?
So you're going to give another dose of infliximab, increase dose to 10 mg per kg this time, or just a quicker dose on day 3, day 5, day 8,
Yeah,
or
a
whatever?
quicker dose or a higher dose, because you gave 5 milligram per kg body weight with low albumin at that point in time. Because I'd like to rescue this colon as far as possible, because it's a very young girl, and we don't know in future we might have much better drugs coming in as well. So I would.
What about
give a
sequential
second
therapy? Why
try.
not add cyclosporin now? What are your thoughts on this? Rupa?
Cyclosporin, I wouldn't switch, I think, from infliximab to cyclosporin because addition of a new drug, but I would feel that the patient is a little better than before. The frequency has come down. The general condition is a little better. In the situation, maybe giving a second dose and waiting for another 72 hours may be worthwhile. I wouldn't add a new drug at this point in time.
Simon, refer to the
just chip in quickly there. I think adding in cyclosporin in these circumstances will be ill-advised because you're compounding the immunosuppression. And there are certainly the French Jeté group did it, and that's how there were hepatic abscesses, pneumonia, and whatnot. So I think that's ill-advisable. I agree with Rupert that actually increasing the giving another dollop of infliximab is reasonable. Though, Naresh, I think this patient refuses surgery. Well, okay, but that's one very good reason for introducing the surgeon to bring it right, get the elephant into the room and to get right at the third day, because that helps discuss and the family discuss rather than presenting an ultimatum. Because this is how patients die, because physicians just add in another therapy or whatever. So I think you've gone with infliximab. That's fine. I don't think that's wrong. It was, but I would give more infliximab. But I would also get the surgeons in to see her to talk that through, and if necessary, meet a patient who's had a colectomy.
I think
we have a combined medical surgical unit, so the surgeon was in on day 1 itself. But yes, your point is well taken that the surgeon talking to the patient gives a different perspective as well.
so. We will pray with the family and the surgeon.
Okay.
So after the second dose.
What about prayer? You don't believe in that?
No, is the short answer, Naresh. I gather that they looked at the power of prayer for improving outcomes from coronary artery bypass grafting, and I gather that there was no impact on the outcomes. But
Okay.
I'm not aware of any similar study in acute severe colitis.
Okay. All right. So this is what we did. 20 mg of tofacitinib for 3 days. Just very little evidence for this. Vishal Sharma from PGI had put on a meta-analysis. Now, you did mention this earlier, Simon, about Dopha being an option, a cheaper option. What are your comments? Where do we place this?
So only the dose that the Ann Arbor pushes hard. Peter Higgins is CG8.
30, you say, 30 mg.
Yeah. And although I can't remember who the first author was, but they use 30 milligrams daily, and it's interesting. I once again, I don't think this is wrong, but it's uncharted territory, and Are you adding the same risks as with cyclosporine? We've got evidence of the harm of cyclosporine, and for the reasons that Vandana pointed out about the low albumin and the benefit of infliximab, that's interesting. So Topha is a useful adjunct, but I would have been speaking carefully with all of my colleagues and also testing the refusal for surgery here, because we know that collectively saves lives, and it's lives are what matters, not saving cows.
Yeah, there's some studies which have used 20 mg per day, and because, as you said, it's uncharted territory, we decided that we would go on a lower dose. But your point is well taken that 30 could be an option, and the thing of adding another agent would have perhaps increased the risk of infections as well. But just to put in perspective, where do you see the role of tofacitinib in ulcerative colitis?
Yeah, it's a difficult one. It's a very nice question. I think that Topha, I think will, were it not for its rare side effects of perhaps thromboembolism and zoster, don't underestimate zoster. I think that it's a good agent. It will be the first or second choice of advanced therapy. I think vedolizumab is my first choice of advanced therapy for maintenance of remission these days, not anti-TNF therapy. But that's not in these circumstances. It works fast. It's going to have a role in acute severe colitis, I do believe, and I'm interested that in this meta-analysis, there were clearly some people who had had anti-TNF therapy. We need to look at the safety of those outcomes, and if that's an option, well, I think what you've done is an intelligent and sensible approach, and I hope it has a good outcome.
Yeah. So 4 days later, bowel movements
there's the CRP coming down.
Yeah, she did well, and so we found that finally this work that we continue. She's presently continues to be on Topha. We're planning to reduce the dosage over a period of time. So what is the recommendation on that, Simon?
So you give 8 weeks of 10 milligrams twice daily, and then switch down to 5 milligrams twice daily. So Naresh, I've got a question for you. She's 25, 26. What about Topha and pregnancy? How long are you going to continue this for?
I don't know. It's uncharted territory, so I'm looking up to people like you for help.
No, it's you do not want to give Topha during pregnancy. I think here, can I suggest it a third way, because this is way off evidence base and is very tenuous. So I think Topha is a useful drug. It's an evolving role. For this particular circumstance, I quite like the option of them moving from Topha, or for that matter for cyclosporin, onto vedolizumab. So Vedo's safe, gut specific, if finance allows, it's a very, very nice option. So I would use Topha to get her out of the woods, and then I would not use it long term because she's a young woman, but I would move on to Vedo.
Thank you, Simon. Thank you, all of you. Just a final thing, comments from all of you. Could we have managed this lady any better? Right from the beginning, we spoke about how we could have monitored her better, and to prevent her relapse. We could have predicted an ASUC based on the initial risk stratification. But anything else that we could have done better?
Naresh, I think it's honest of you to ask that question. I think that's a tribute to you, because one should always reflect on how you might have. To be honest with you, I'm not sure that you could have done within the evidence available. I think that we do not know if somebody has high risk of getting acute severe colitis, whether if we weighed in with more advanced, more powerful therapies, that will make a difference. But I think that the managing the patient, their family, I think that you did well, and you used, you clearly considered, discussed. I would pay tribute when I get my acute severe colitis in Bangalore. I'll come to see you.
Thank you, Simon, for those kind words. Amit, Lubna, and Vandana, any comments?
This is a very well managed case. Only one point I had to make, which I think we should discuss with Dr. Vandana and Dr. Simon. Like after the steroid therapy fails, we are saying this patient may be more likely to go for surgery because of the looks of, say, a stigmatoscopy or something. But in many situations, we won't predict that in our practice, that the patient who's failed steroid, because the response rate for infliximab and cyclosporine is similar. And so how to choose a patient is not very easy. Here, because of the depth of ulcer, we could say that, okay, but like for a person who is listening to this program, do they have any other ways to decide surgery will be more likely, or will they still be like, infliximab versus cyclosporine? Anything can be sort of used.
Yeah, I think, see, if it was a 40-year-old or a 50-year-old person, I think, and, resources were limited, perhaps you could have pushed for surgery up front. But if you have a 26-year-old, I think we need to exhaust all our other options before we offer a surgery. I mean, that's the way I would look at it.
I think ultimately, Dr. Naresh, all's well that ends well. I mean, I was very happy for this young lady, and I think once you take her off Dopha, maybe you can even give her biologics or continue that 2-monthly course, and I think it's all wonderfully managed that way.
So don't expect me to get her married off as well.
So I think we have exhaustively covered this, Dr. Naresh. You have covered all aspects of acute severe ulcerative colitis, and I think all the postgraduates who are watching this program and practitioners in day-to-day practice will really benefit from this case. And I think without you, Simon, this discussion would always have felt incomplete. We've had wonderful comments from everyone, and there is an outpouring of questions. And I think there are questions for Dr. Naresh, there are questions for Vandana, there are questions for Simon. We have covered most of the questions, but I'll just ask one question to Professor Simon. There's a simple question: should we stop mesalamines in acute severe ulcerative colitis?
Yeah, thank you. Yes, in my view. I think 5-ASA, if somebody's been taking 5-ASA and they develop acute severe colitis, it clearly wasn't up to the job of maintaining remission. And I can't see that it adds anything to the management of acute severe colitis. I think we know that if you're on advanced therapies, it doesn't add anything to that. So I now stop 5-ASA there. Certainly, given the patients when they're in hospital, then they're already on multiple medications. So I don't do that. I restart it when they're an outpatient if I think there's still an indication.
Is Saurav there? So just very quick answer. Saurav, are you there?
Yes, ma'am.
Saurav, there's a quick question for you. Actually, there are many questions. I'm taking the simplest one because we've run out of time. This is exclusive enteral nutrition. Can we use it for adult Crohn's disease?
Yes, ma'am. We have been using it in our patients, especially patients who are malnourished and patients who have been having a poor response rates to the immunosuppression, and it works very well. So exclusive enteral nutrition can be used in patients with Crohn's disease, definitely.
Thank you. Dr. Naresh, a question for you. There's risks of heparin in acute colitis. You used heparin, but are there risks of overbleeding when they're at the early stage? Or
not really. We have hardly ever seen any bleeding problems in acute colitis, even though they're passing blood in stool. In fact, the benefits outweigh the risks because of the big risks of venous thromboembolism that exists in these patients. So I think heparin is an integral part of therapy, and some collateral evidence that it actually helps with colitis in some way. Some data from UK, I remember many years ago.
Ireland, Naresh, Ireland, not the UK.
Ireland,
and it was the Republic of Ireland, not even Northern Ireland.
So I think questions are still coming in, but we've really run out of time. So there was questions for Vandana regarding empirical valganciclovir, and I think they're just coming in. Should we stop ASA in all acute severe ulcerative colitis? Maybe Dr. Amit, you can just give a one-liner. Should we stop ASA in all acute severe ulcerative colitis when they come?
We don't stop. In fact, we continue ASA because that is probably the maintenance. So it takes some time to set in. So mostly we continue as a azathioprine, or we start as a azathioprine as we start the initial therapy in the patient's actually. So we do give, except for that CMV situation. Otherwise, we give as a azathioprine when they are admitted as a severe colitis patient.
So, Vandana, are you there? Just one-liner, empirical valganciclovir.
Empirically, we are not using unless and until we have a very high index of suspicion and we are awaiting for the biopsy reports.
Thank you, everybody. But before we end, I think this is every month we highlight one country, and this month it is Pakistan. And we have a short presentation, a very short presentation from Pakistan and IBD there. Can we have the video, please?
Hello, everyone. This is Professor Lubna Kamani from Pakistan. I'm currently working also as a residency director in the Acute National Hospital and a consultant gastroenterologist at Bowel University Hospital. I would like to express my gratitude to Professor Rupa Banerjee for inviting me from Pakistan as a part of IBD Emerging Nation Consortium. I believe that this is an extremely important and much needed initiative from South Asian countries because through this platform we can better engage for the research projects and collaboration and more academic engagement in future. Regarding IBD status in Pakistan, unfortunately we don't have any IBD registry from Government of Pakistan. So the exact epidemiological data is not available. But over the years, as the healthcare access is improved in Pakistan, so diagnosis is not a challenge these days. But as improvement in healthcare is more accessible, we are seeing more and more cases in the younger age group in Pakistan. The way we face a couple of challenges in Pakistan regarding inflammatory bowel disease. The first of all is the overlapping features, the clinical and histopathological features of Crohn's disease and TB. And TB is endemic, so it's sometimes difficult to differentiate between these two diseases. The second big challenge that we face in Pakistan is availability of biologic therapy. And it is sketchy available in some parts of the cities and in country. It is not available everywhere, and the cost is a major burden because usually patient has to pay from their own pocket. But things are getting better, and I believe through this platform of IBD in Emerging Nation Consortium, the healthcare of the patients, the awareness, the treatment would be better in future. As with India, we share common border, we share, a common culture, the various diseases. So the disease course will be also, I believe, similar as in India. We don't see much complicated patients of inflammatory bowel disease like fistulas in Pakistan. It's rare. It's basically we see mild to moderate disease, which are managed with oral medications. So all the best for the webinar, and I'm delighted and honored to be part of this extremely highly important initiative, and all the best to Professor Rupa Banerjee. Thank you very much.
Thank you, Lubna. And before we end, I'd like to thank Professor Simon once again, Dr. Naresh Bhatt for being there, the extremely talented panelists, Dr. Saurabh especially, he has made time from his busy schedule today. He was in fact supposed to go somewhere, but he has managed. And I think this was a really all-encompassing talk on acute severe ulcerative colitis. Before we end, for the next session, it is going to be something which we need to know, particularly for the postgraduates. What are the basic sciences in IBD, including environment, factors, or why it is increasing? So this will be an exciting session as well. This is on 27th May, and I'm looking forward to having all of you there. No program ends before thanking our academic partners, and I'd like to take this opportunity to thank Janssen, Dr. Reddy Labs, Microlabs, and Takeda for supporting the IBDENC initiative, the web page. Please join us at www.ibdenc.org. All membership is free, and we all get to partner together for IBD. Thank you, and thank you once again. Good night.
Thank you.
Thank you.
Thank you.
All good.
Bye-bye.
Thank you, ma'am.
Thank you,
Thank you so much.
Thank you,
Thank you, Dr.
All right.
Naresh.
Bye then.